Hello, my name is Heun. I'm a consultant psychiatrist, and today I'd like to talk about the treatment resistance and how to manage it. It's in the series Global Psychiatry Archives, Mental Health Explained. So by the end, you will have an understanding of how to manage treatment resistance in schizophrenia, and you will have some ideas how you can help your patients in a better way. Treatment resistance is usually the failure to respond to two or more antipsychotics, which are given in a full dosage or a therapeutic dosage for at least 6 weeks each. People who have symptoms after these medications are more likely to have other abnormalities of the brain structure or neuropsychology. So sometimes there's an overlap between schizophrenia and minor cognitive impairment. Right, the prevalence in the people with schizophrenia of those having poor response or no response to antipsychotics are about 30%, and about 5% have nearly non-response to medication. So usually you have two antipsychotics. I think sometimes it's not enough, because when these developments, when these guidelines from the Royal College of Psychiatry were developed, there were other medications which have been developed after that. So the usual recommendation is to give clozapine. First, I look at the etiology. The etiology of treatment resistance in schizophrenia is unknown. There's some factors which you can sometimes see in patients who have no response or little response to antipsychotics. They might have neurological soft signs, minor neurological abnormalities. They might have a history of obstetric complications. They might have some cognitive impairment. Some of them have non-compliance to drugs, and sometimes when drugs are given insufficiently, they stop working properly. There's no good science on that, but there's clinical experience on that. The science is usually quite difficult because patients who are non-responding to therapy are not patients who are very willing or who are the best patients to take into a randomized clinical trial. Right, there's also a lack of adequate treatment, which is a risk factor. It could be that the drug is not absorbed, the drug is poorly administered, and sometimes if it's treated too much, that's more or less an anecdotal evidence that if there's overtreatment, then there might be poor tolerability of the medication. Sometimes you can't go high with an antipsychotic simply because there are so many side effects. Right, and this is one of the major problems in the clinic, is that people taking drugs. Alcohol is a problem in people with schizophrenia, and sadly, cannabis. Cannabis is very often taken to sedate, and people have little insight that some of the psychotic symptoms can be caused by cannabis. Right, other medications rarely can cause treatment resistance. Some people say it's antidepressants or anti-Parkinson's medication. However, again, these experiences are more anecdotal. To manage this, and I'm talking here about treatment-resistant patients, and sometimes personally I would say treatment resistance is not just resistant to two antipsychotics, because we have other medications. We have the old classical antipsychotics like haloperidol and benperidol, which is under Glianomone marketed. we have newer medications, including risperidone, amisulpride, aripiprazole, clozapine, and olanzapine. And in my view, and coming to the medication, in my view, before patients are treated with clozapine, there should be more than 2 medications tried for at least 6 weeks. Sometimes you have patients who respond to amisulpride and nothing else. And this is a very funny or very difficult situation in psychiatry. We honestly do not know why one medication works in one patient and other medications work in other patients. So there's many things which haven't been clarified yet, and we need to have more and better studies. Right, so what is the management? We have to clarify the diagnosis. Is it really schizophrenia, or is it a personality disorder? Is it a patient with lots of comorbidity? As I said, substance abuse can be a problem, and sadly it's also common in people with schizophrenia. Non-compliance is one of the biggest things. People do not like the medication, and the only way to manage that is to try to get a relationship and have psychoeducation, compliance therapy, or family therapy to improve compliance. So it must be the education about the medication that should be proper and comprehensive. So in patients who are not responding to more than 2 or a series of newer antipsychotics, then clozapine is an option, and it has a slightly better response, but it has many side effects. And sadly, you have to take bloods all the time, and we have another video where I talk about the clozapine medication. Clozapine resistance can also be a problem, which is rare, but happens. People from clozapine can then try to go to another antipsychotics, secondary type of antipsychotics, such as olanzapine, risperidone, or quetiapine, and sometimes they might have a better response to that. In some cases, you can augment clozapine, which could be with benzamides, which is sulpride, amisulpride, or antiepileptics, and a newer version would be to augment with aripiprazole. There are lots of other interventions, non-medically, which are rehabilitation, looking for rehabilitation facilities, which sometimes provide a better quality of life than people being at home on their own. So very often the family can be overwhelmed with the work they have to do. Right, so sometimes, and this is things I haven't mentioned now, is the use of high antipsychotics. Very, very often in the clinical practice, we see patients who haven't responded to one antipsychotic. And then what we do then, we combine medications. So medications could be combined experimentally. So you can combine haloperidol with a more sedating one, which would be Nurosil, promethazine, and would be a medication combination. This is something which has been done in Germany over the years. The more American approach for acute psychosis was to give a benzodiazepine for sedation and a high-dose antipsychotic for the antipsychotics or paranoid symptoms. Right, so it should be very clear that if you do this medication, a combination of 2 antipsychotics, that it's very time limit, it's an individual trial, and it should be very clear what you do, and there should be a clear limit of the expectations that this type of medication is not done endlessly, or that people are having medication added one after the other, and if it doesn't work, it's not taken away. So there should be a clear plan for clinical review. There should be some safety monitoring of blood pressure and blood levels of the medication, and there should be a physical health monitoring as well, which includes heart, liver, lungs, and gastrointestinal system. Right. If there's a clear evidence that combination work better than one medication, it should be checked whether the benefit of the antipsychotic outweigh the risk or the side effects. There's no point when people have no proper quality of life, and a patient once told me that giving or taking the medication is more like death warmed up than a real life. So some patients choose to have some symptoms and have a better quality of life than being over-medicated. But that's something where clinical practice comes in and experience comes in, and usually there are also some local recommendations to monitor these high-dose medications, and as usual, you have to follow the local guidelines. Okay, I hope that you learned a little bit. So treatment resistance is not completely treatment resistant, but it's a criterion for initial failure of 2 or more medications. And then, as I said, you have to swap to clozapine or to high-dose treatment with the considerations I gave a couple of minutes ago. Thanks a lot for your interest, and if you have more interest, please join the Global Psychiatric Association and subscribe to this website, Global Psychiatry Archives. Thanks for your interest and have a nice day. Thank you. Bye-bye.